ketamine can be a very transformative experience. If I had to pick one word to describe it, that would be the word. And that's what we're trying to create, okay? It is highly impactful. The response rate is very high. So I expect about 76% of the patients to have improvement, okay? Some level of improvement. I expect about 30% of the patients to have remission, at least in the short term, okay? So 25 to 30% here, all right? And then the other like 40 to 50% to have moderate improvement. And then of course you have, 25, 30% non-responders. Because this is not a magic bullet, it does not work for everybody, and this works better in conjunction with everything else than it does completely by itself. Because you'll have some patients that want to stop all their medicines and not see their therapist because they think this is a miracle drug. You need to tell them to stop. Don't do that. Do not stop your medicines. Don't stop seeing your therapist. In fact, I found this better to start a new antidepressant or adjust your antidepressants and do this is better than just, doing it by itself. And we'll talk about patient selection in a minute, okay? So the response rate is high, but here's what they experience. It's a lot of different things they experience. I can't even write it down. It's better to just describe what people tell me. So since ketamine is a dissociative, and a lot of times you hear people describe it like a psychedelic, but it's different from what you expect, especially if you've never done drugs. I think a lot of times people think like, oh yeah, psychedelic, you're just seeing colors everywhere and everything's distorted and you're thinking, oh, weird and it's trippy and scary. Well, ketamine is a very internal experience. It's not an external. So if I'm like on ketamine and I'm looking in the room, well, I kind of see what's in the room for the most part. It may be more blurry, it may be more wavy. I may pay attention to details I wouldn't normally pay attention to, but it's not like I'm seeing flying elephants and stuff like that. Typically don't. However, in my mind's eye, there's a lot of stuff going on. You close your eyes. Common things that people describe is just like colors, fractals, the universe, stars flying through the universe is very common. Emotional experiences, empathy, love for yourself, for others. Connectedness is a very common description. Spiritual connection, like feeling God's presence very clearly, or hearing God's direction for your life very clearly for my Christian patients. Sometimes my non-Christian patients have that experience. I've had patients who have reconciled with loved ones that they've lost or disenfranchised or they died or something like that. Here's a story. If you look on fixmydepression.org, there's a gentleman that left a testimony. His story that his father died in a agricultural accident. They burned the fields each year, and he got caught in one of the controlled burns, severely burned him, and ended up dying from his injuries. And the patient held a lot of guilt because he was the one that started the fire, and he got trapped in it. And he carried this his whole life and was a root to his depression. And during his ketamine experience, his father came to him and grabbed his hand and reassured him. And he said his father was restored and back to his normal self. And he reassured him that he was okay, that he was with Christ, and that it wasn't his fault. And that was like a transformative moment for him. And in his subsequent ketamine treatments, you see him do this. He shake his dad's hand. And then you see him do this. And he'd be rubbing his children's head because he was able to introduce his father to his children that he never met in this ketamine experience. And that created a lot of peace for him. Okay. So people can have very complex experiences like that. Sometimes it's just images and fractals and just emotions associated with it. But it has a variety of things that can happen in these experiences, and patients need to be protected in that space. So there's two concepts that's really important for these experiences. Set. And setting. I don't know why my I is a lowercase I. Everything else is. Okay, so set and setting. Set refers to the mindset. So the mindset that a patient goes into these treatments will oftentimes reflect and dictate the experience. So if I come into it and I'm very anxious and I'm like vibrating and I'm super scared and I go into a ketamine experience, it's a lot more likely that it's going to be dysphoric and intrusive and unpleasurable. So part of our job is to help people get into the right mindset to prepare for these experiences. So we're kind of in the process of overhauling the whole process, because when we first started, it was just medical. Give the medicine, people get better. And then we realized, wow, the mindset and the therapy and the preparation is way more important than we thought. So now we're like scrambling backwards to invest in making sure that we do a lot more prep work. So now we like get counselors and we're assigning people's jobs. So it's been taking a little bit longer than I thought. But eventually what will happen is we'll have a lot of prep work before they even touch the ketamine. Okay. So mindset is important. And a lot of times there's a few things we like to do. One is nurture, so they feel comfortable and they feel like they can trust the team, because you're going to be under the influence of a medicine and you're vulnerable. And it's like you may feel like you're leaving your body. So you need somebody to be in charge of your body while you're away. Okay. So we are the steward of their household while they're on their trip. Okay. Two, in my opinion, is intention. Helping patients and reminding them to have a purpose and an intention of what they want to accomplish with this treatment on that day. So oftentimes we'll remind the patients to set an intention, and oftentimes I encourage them to bring it down to like one word. Do you need to move your chair?
No, it just that intention.
Yeah. That intention?
Yeah.
Okay, all right.
Another word.
I'm distracted. Anyway, so being intentional with these treatments, we want to encourage the patient to do that. And oftentimes, like as the medicine kicks in, they can't focus on really complex themes. So I try to get them to like narrow it down to like 1 or 2 word themes. Today's intention is peace. I just want to experience peace or harmony in my household, or, release, or I want to forgive, whatever it may be. I like them to have an intention, but I want them not to have any expectations. So don't have any expectations, because you may have an intention of peace and then you have an experience and there's a lot of chaos in your mind. Okay. So sometimes when patients hold on to the intention too much, they start fighting the medicine. Right. So the imagery I like the team to describe to the patient is the patient's job after they set their intention and the medicine kicks in is to be the observer of their thoughts and emotions. So I tell my patients to imagine that you're laying on your back looking up at the clouds and you're cloud watching. And I remind them that when you cloud watch and you look at the clouds, they look pretty static. Like it's like they're not moving usually, right? And you're laying there and you're trying to interpret what these clouds look like. But if you were to get up and go inside and, eat some lunch right quick and go back to the same spot, the clouds are going to look completely different. And a lot of them have already passed through. And that's how your thoughts and your emotions are during the ketamine experience. It may feel real, it may feel intense, it may feel whatever, dysphoric, or maybe a bad memory. But guess what? You're just there to watch it and understand that it's going to wash over, wash through, and wash on by. And you're on to the next thing. So I think when people have that understanding, they don't get so locked in on a fearful thought if they have one during ketamine, because they've been instructed. All right, I just need to breathe and let this pass through. Okay. Sometimes they need reassurance for that. So it's okay to touch the shoulder. You notice they're getting kind of anxious. Their heart rate's going up and they look uncomfortable in the chair. Ma'am, are you okay? I said, okay, I touch you. You're safe. I'm here. Your vitals are okay. Just breathe through the experience. Just watch just pay attention to what you're feeling and just let it go. And just be really purposeful about your voice and your presence. Okay, because you're protecting their environment, okay, while they're going through the experience. That's the main job once she gets the medicine in, okay? So intention, no expectation. And a lot of times I like to do breath work and relaxation work. So I want to share probably my most common technique I'll use to kind of prep the patient. And this is, and I encourage the nurses to do this with the patient. You won't be able to do this all the time because but y'all will be fine because you got Angel there too. And we're not busy enough for you to have like 5 people going at once. We don't have space for that. Right? But eventually it'll be like that. So, but when you have time, I want you to make a nurturing environment, help the patient set an intention, tell them not to have expectations, tell them what to do with their thoughts and emotions, and then after you have the IV in or something like that, work through the breath work because there's a period of time that the medicine didn't kick in yet. So I want them in as relaxed state as possible so the medicine can do the work it needs to do. So I'll teach usually 2 different types of techniques. One, well, actually it's 3, okay? So usually, then I'll give you a script. I'm pretend I'm helping the patient. Okay. So I may say something like, so what's your intention for today? And then the patient, because I've already kind of taught them this stuff. And they've been thinking about it. And said, well, I think my focus today is just rest. Okay. And so I'm very, very intentional about how I use my voice. I lower the pitch. I slow down the cadence because my voice needs to match the emotion and feeling I want them to have. Okay. And I may say something like, good, that's a good intention for today. I validate them. So I want you to find a very comfortable position in the chair. And by this time the recliner's laid back or whatever. Find a really comfortable position for yourself and just allow yourself to just close your eyes. And let's just do 3 deep breaths. And then I'll instruct them directly. Inhale through your nostrils, filling your chest first, and then your belly. And then when you can't take it anymore, just relax and let your body relax and to expel that air. And I'll let them do, and I'll sit quiet. Let's just do 3 breaths. And I'll just watch their chest rise and come down. 1, chest rise and come down. 2, chest rise. And then I'll kind of go to my next direction. Okay. As you release this next breath, I want you to imagine that every molecule of air in this room is just a small portion of your intention. Just a small portion of rest. And on your next breath, I want you to visualize that rest just coming into your nostrils. Feel the sensation in your nostrils. Right now I'm doing imagery. I'm distracting them from all their anxious thinking and all their expectation, what's going the best I can, right? Imagine each molecule of rest just coming into your nostrils, filling your chest, filling your body, and then permeating all of your cells. And then as you exhale, imagine any barriers to your rest just leaving your body. And then I'll have them maybe do two or three breaths like that. Deep inhale in, rest. And so I tell them I breathe with them because I'm modeling it. Because sometimes people are so anxious, you tell them to deep breathe, they'll be like, right? So I may model it. And now I'll audibly breathe. So they can hear it and they'll try to match your breath when you do that. Okay? So I'll get them maybe do 3 more breaths. So just kind of imagine their intention coming in, releasing any barriers of it. So now I've kind of done some imagery and I've done some breathing. And then I'll kind of transition to like what's called progressive relaxation. You may have heard of that before. So basically I have them, now I want you just to imagine with each exhalation, just imagine your body melting into the chair like cold butter on a warm skillet. So when you exhale, next time I want you to focus on the sensation in your shoulders and arms and back. As you exhale, just melt into the chair. Now this time the medicine is starting just a little bit in there, okay? And just melt into the chair, and I walk them through the body. Just imagine just your chest and abdomen just relaxing and melting into the chair. Imagine your glutes and legs, hands and feet are just melting in the chair. And after they do a few breaths, now just imagine your body just completely relaxed. And then I'll just kind of strategically put pauses in there so they can, hopefully what'll happen, you'll notice their breathing rate is deeper and slower, right? and they're more calm and they're still, right? Because in my mind, I'm trying to coach them to be still so the medicine can do what it needs to do. Okay, so this is the advanced level here, okay? Now, so once I kind of got them to that state, and I'll just kind of direct them now. I'll say, momentarily you'll notice that the medicine is kicking in. I want you to keep breathing. If you want to breathe normally, you can. If you want to come back to this deep breathing, you can. If you get fearful, just breathe. We're here. You're safe. Okay? Sometimes if there's somebody really anxious, we've done thousands of these treatments. Everyone's been safe. You'll be safe too. And I'm just real calm and peaceful about everything. And then once I kind of got them to the space I want to step away, I'll just say, I want you to continue to breathe. I'm going to step away. Or I may ask them, how do you feel? Oh, I feel relaxed. Good. Hold on to that. Just breathe. I'm just going to step away. I'll be right here in the room. If I'm the nurse or I'm the doctor, all right, Cassandra's just going to take good care of you. I'm going to step out. Then I say something corny. I say, have a nice trip. And I walk out. And I usually walk out. So usually like that's kind of my process, and it tweaks and it's kind of a little different for each person. But I'm using imagery because I'm trying to distract them and trying to get them in their mind's eye. I'm using breath work because the body follows the breath. So when you have a sympathetic response, the tiger's coming to eat you, your heart's beating fast, and you're sweating, and all the fight or flight mechanisms on, all of that is automatic because it's coming from the autonomic nervous system. But the one thing you can't control is your breathing. You can control your breathing. You have conscious control over it. You don't have conscious control over anything else. So sometimes I'll teach the patients that, and then I'll use the breath to try to get them into a parasympathetic rest and digest state, because that's what I want, okay? And then I'll kind of ease out, all right? So that's kind of the prep work you want to do like right before a session the best you can. And after you do it once or twice, the patient will kind of know. And you may not have to do it all the way like that. But that's the very first session. I like patients to do that, okay? All right, so that's kind of the mindset. Second part is the setting. So the setting is just like the environment. I'm very detail oriented when it comes to these experiences. So I do a lot of the ketamine assisted psychotherapy with some of my personal patients, and I get super meticulous about this room. I'm paying attention. I sit down where they're going to sit at. I look around and see what they can see and make sure there's nothing that's going to distract them or clutter, because I'm a clutter bug. And I'll look around and I'll make sure and I'll move everything around and I'll straighten it out, because some people don't like disorganization. They'll see the pen this way instead of straight, and then it will bother them. So I'll walk through and I'll sit down and I'm like, all right, move this. Oh, there's a sticky note right there. Move that. Da 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 da. I move around. All right. Oh, there's chairs. I see some hairs on there. I'm going to wipe the chair down. I'm just going to make it. I'm protecting their environment because I don't want any distractions from the experience. Okay. I'm paying attention to the temperature in the room. If it's cold, I'll make sure I got a blanket available, right? Et cetera. So you see where I'm going with this, right? So I'm trying to protect their environment as much as I can. A lot of times if I know the patient, I'll dim the lights before they even come in, because I know they're going to be anxious. Dim the lights, open the blinds, natural light, not artificial light, right? I'll have them sit first, then I sit. So I'm just very meticulous about the environment. So you want to control the temperature of the room best you can, the smell in the room so it stinks. You want to make sure you kind of wipe it down to sanitize and stuff like that. I try not to like over sanitize, because that really strong sanitize feeling, people don't like that. Also, as I get to know my patients, some patients don't mind me like burn candles. Like I got candles up there, I got aromatherapy up there. Some patients hate that. They're like, oh, why would you ever do that? I have allergic reaction. This is their medical fatigue. So I don't do anything the first time, because I may ask their preferences. Okay. So I want to control the smell of the room. Sound. I want to protect them from sound. So since this is probably the most important one to me, because the best way to pull somebody out of their experience is have some loud distraction while they're in that experience. And they be chasing, they're finally about to let go of their trauma, and then they hear people laughing and stuff outside the room, and then they lose it, right? So when I'm doing CAP, oftentimes I'll have them use headphones. So we encourage them to have noise canceling headphones or earbuds. And typically I'll tell them to listen to music, but it has to be instrumental, nothing with lyrics, because that distracts from your own internal thought process, right? So only instrumental music. Oftentimes the beats per minute will determine or not determine, but influence how they experience the ketamine experience. So if it's too, it elevates the energy, and sometimes that makes you more anxious. And sometimes counterintuitively, if it's too slow, it's droning, and then it actually makes them more depressed. Like, so the patients kind of have to play around with what seems to make them feel better during the experience. So I just explain it to them. Like, if it's too slow and it made you feel more down, pick something a little bit more upbeat. If it's too upbeat and it made you feel anxious, bring something a little bit down tempo. And I try to explain to it. Most commonly, I think the best thing is like nature sounds. Water running, birds chirping, wind rustling leaves. That's really good for patients. I usually, if you look on YouTube, you'll see stuff like delta wave music or alpha. What that refers to is like the frequency of certain tones, and the brain tends to sync with music. So you can, sometimes I'll have them like, all right, I want you to listen to a beta frequency or a delta frequency because I'm trying to bring them up or down or something like that. Most doctors not that meticulous about it. And since I'm not doing every treatment, I don't recommend that usually. But it's at your discretion as you get knowledge of this. I would probably go on YouTube and listen to some different ones and just try to make some recommendations for them. But you really can't make a recommendation to experience ketamine yourself because you don't know how it actually makes you feel. Okay. Some of the employees have experienced ketamine after clearance and everything else like the other patients, so they can have the language to talk to the patients about it. I would probably say 75% of us have done some type of experience. Okay. Quick story. So there's a company called Mind Bloom. It is probably the largest provider of at-home ketamine in the country. Okay. To us, that's a competitor. So I ordered Mind Bloom. I got cleared by the doctor or a nurse practitioner. They sent me the medicine and I went through the experience to see what it was like. It was very awesome. So I have a lot of empathy for the people here. But one experience, the music really messed me up. So there's, like the Aborigines in Australia, they have the thing, the what is the thing called? I don't know if you know what it is, but it's a instrument that's kind of characteristic of Aborigines. And I was on YouTube, I was like, oh, that'd be cool. That's probably like really like nature tribal, yeah. So I'm listening to this like tribal beat and it's playing this like really low resonance thing. And it made me like so like messed up during that experience. I was just like, oh my God, this is terrible and the world's awful. And all I could focus on was like everything that was wrong in the world. And it was like just the most worst experience. And then I was like on my treatment. So I just couldn't figure out how to use the phone appropriately to change the music. So oftentimes I'll caution the patients about their music choice and give some examples of some things that might not be the best for them. Like I have some patients that listen to like death metal and stuff like that. I'm like, no, don't do that. That's like counter to what we're trying to do. All right. So you want to put goodness in to get goodness out. Okay. All right. I spent a lot of time on that. So that's kind of just our big things. Help them with their mindset and protect their environment. Controlling the temperature in the room, make sure the room doesn't smell like hot garbage, protecting their sound. I'll usually tell the patient noise canceling headphones over the ears better than earbuds because they fall out. And eye mask because it's an internal experience. That can change the game for a lot of patients. I have patients that's come here a year, wouldn't follow our directions, and finally put that eye mask on, the headphones on, and have a completely different experience, okay, with the same dose. So I highly encourage that for your patients. All right, any questions about that or anything we talked about so far?
Not yet, no.
Okay. Do you find this helpful?
Oh, yeah.
Okay, very good. All right, so at this point, we got some theory. We understand a little bit about the medicine. We understand about the prep and kind of prepping the patient mentally, emotionally for the session. And then finally, we're going to transition to like the procedure. And then I'm going to put you with Santana and Michelle this afternoon to go procedure. We have one Spravato patient at 1. You can just kind of shadow. Angel will show you that more thoroughly. Okay. And then we might have an IV ketamine added on. He's seeing one of the DMPs this afternoon, and he drops from like an hour away. So they may put him on the schedule based on how that appointment goes. So we might say an IV before you go today, but I'm not sure. Regardless, they're going to walk you through the procedure. Here's how we do it. Here's how we log the ketamine. Here's how we draw the ketamine up. And here's blah, 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 blah. One thing we typically do with the dosing is, like I said, we kind of have a standing order, 0.5 mg per kg when they come in. but we adjust it based on the previous experience. So in the notes, it'll ask, we use language like, we use scales. So 0 to 10, if 0 means you didn't feel the medicine at all, you took a sugar pill, or, you take a saline bag. 10 is like, I was fully dissociated. I was in the K-hole. I couldn't feel my body. I didn't know where my body was at. I was a spirit. That's 10. We'll ask the patients kind of rate their last experience so we can adjust the dose. Usually I like to keep people somewhere between the 6 to 8 range on their kind of personal interpretation of how it went. Because it is possible to get into a K-hole. We didn't talk about K-hole. K-hole is basically an experience where the dose of the medicine is too high, too fast. And the patient's, it's basically an anesthesia. You lost all perception of your body, but you're still conscious. You can't tell if you're breathing. You don't know if you're alive. You think you might be dead. You're just a spirit. And you can't get out of it. You feel like you can't move. It's pretty scary. So we try to avoid the K-hole at all costs, okay? I always tell you the analogy, if the K-hole's over here, I like you to get over here. Okay, I see it. I'm good. I don't need to go down there. That's kind of where I try to get patients to in the treatment. And the only way to get there is kind of gradually get closer to it without overshooting it. We got 7 minutes. So the nurse will probably talk to you about this. There is some level of tolerance, and we didn't talk about addiction and abuse, and let's use the last few minutes for that. So ketamine itself does not have like a biological dependence, like say alcohol or opiates, okay? But it can be abused because people chase that euphoria. Because when a good ketamine treatment, people feel like $1 million, okay? They love it. And people can chase that experience. And that puts it in position for abuse if we're not careful. So we have to be careful about how we select that patient, careful about who gets it at home, okay? Otherwise, it's all controlled by us. They can't get access to it, okay? There's also a little bit of a tolerance phenomenon for some of the patients. Not all of the patients. Meaning that, oh man, 50 was a really good dose. Next time you did 50, that was a lot milder. I didn't really experience it the same, so now we got to do 60. So what you'll see when you look at the logs that they show you individual patients, you'll see they started this dose and now this dose, now this dose, and they've been in the program for, 5 months or 6 months, and they kind of leveled out in a certain range. And you don't see as much variability once they kind of get to a stable spot. But you will get some level of tolerance, so the jumps get smaller. So before he was like, oh, we did 50, we probably should do 60. Oh, we did 60, we probably should do 70 or 75 total dose. Oh, now they got 100. Oh, 100 seems to be their sweet spot. There'd be 100, 105, 100. Oh, that last one's kind of strong. We backed them down to 95. So there'll be kind of a range within about 10 milligrams, typically, once they're kind of stable, okay? But we think that's from just kind of tweaking the experience and trying to get them as close to where we want them to be, but also some levels of tolerance. You get used to the experience, you feel safer in it, you're not as afraid of it, and then you'll see that escalation of dose. And then over time, sometimes you get a little bit of tolerance, but you only see little smaller jumps in the treatment. So one thing I didn't cover is the treatment course. Duh. I can tell I haven't taught anybody in a long time. All right. So we'll go through this and we'll be done for today. And then I'll have lunch. And then I'll have with the nurses this afternoon. Okay. So CAP is ketamine assisted psychotherapy. So IV, all of these are exception of CAP. CAP is kind of its own thing. I'll go ahead and jump to CAP. CAP is at the discretion of the clinician. So there's not a set amount of times we do it typically. And hardly anybody goes straight to CAP. Most of the patients are doing this and then they'll graduate to this, okay? Probably within the next 6 months, we'll have patients that come direct for CAP because I'll start marketing for it. But I gotta get the workforce ready, okay? There's an induction phase, almost like a loading dose, and then there's a maintenance phase. For IV, the induction is 6 treatments over 2 weeks. They do 3 per week, and then we reevaluate. The cost of this is $600 per treatment. So patients initially invest $3,600, and then typically in the maintenance phase, most patients will need 1 booster, anywhere 4 to 8 weeks. Some patients can go longer, okay? Some patients come quarterly, some patients come once or twice a year, depending on the patient, how robustly they respond, how long it lasts for them. So the reevaluation and the conversation, part of that is, has there been any decline? So basically they'll do 2 weeks of the treatment. We usually would do their ketamine evaluation 2 to 3 weeks after that. And one of the questions we're trying to observe is, did you get any decline? One, did you get improvement? If you got improvement, was there any decline between your last treatment to now? Because it's only been 2 to 3 weeks. If there's no decline, all right, you'll likely be good for at least a month. So we usually will schedule the first booster at a month. And then if there's no decline over that month, the next one we'll schedule for 6 weeks. If there's no decline over that period, we'll go for 8 weeks. Most times patients are like, oh, about five weeks I was noticing come down, so I might put their interval about every 6 weeks or so. Okay. The nurses are really important for patient continuity and make sure they're coming back. So a lot of times I try to encourage nurses, try to schedule their follow-up before they do their treatment, because they do it after treatment, kind of inebriated, and they can't look at their schedule, and the driver doesn't know when to bring them back. So my opinion, try to reschedule them for the next follow-up based on where they are in the program before, and typically we schedule all 6 when they first start. But keeping them in maintenance is important though. Okay, so if you know they're coming every 6 weeks, go ahead and have them schedule that 6-week follow-up before they do their treatment, because the nurses don't always do that. And then the patients will be feeling good, and then they start rationalizing that they're still feeling good and they don't come back, and the next thing they know, they're back at the bottom, and they feel like they need to start over, and they don't want to spend that much money again. Okay, so you're really important for that. IM is a little different. So IM and Spravato have the same schedule for the most part. So IM has more flexibility. So let me tell you the Spravato schedule. Now the Spravato schedule is determined by the FDA, and we follow this religiously. Okay, they have to do this, or the insurance is not going to cover it. 1, 2. Okay, 1, 2, 3, 4. Okay, so this is only going to be the days of the week: Monday, Tuesday, Wednesday, Thursday, Friday. Oh, I did it right. So the treatment protocol for month 1, still an induction. They do 2 treatments a week. Treatment here, treatment here. Treatment here. And it doesn't have to be exactly like this. We do 2 a week for a month. Okay? Then we kind of get into optimization phase and maintenance phase. Typically they go to then they go from 2 a week to 1 a week. Okay. And then maintenance can be anywhere from once a week to once every other week. And it's just ongoing. Okay. Since lunch is not here yet, this will be ongoing. So if the patient stops Spravato, they tend to go. Okay, so we got patients that have been doing it since 2019. And just come once a month or once every 2 weeks or something like that. Insurance covers it.
So I could do it for like years.
Mm-hmm. So that kind of quickly, I want to quickly kind of show you the data from Spravato. So Spravato has a 7-year study. It's been out since 2019. So they started the study obviously when they did the FDA trial. So they got patients that are still in this study that started in like 2016 that are still taking Spravato. And the main 2 points you need to know is efficacy-wise for, if we look at PHQ-9 scores or BDI scores. So within 24 hours in their studies, the depression rating scales went down. And then I think they used MADRS. The MADRS went down about 19 points at the end of the first month. And with placebo on their trials, it went down about 14 points. So superior. But the thing is, so it's not really placebo. Patients receive standard of care in the Spravato trial, so they got medications and counseling and everything else. And they got medication and counseling in Spravato. Okay? So superior to standard of care. But the kicker is, when you look at this over 7 years, patients keep the efficacy of it over time, which is very, very important. And there's no new safety signals, so they don't get any additional side effects or issues, which we didn't talk about thoroughly, but since lunch is not here, we'll finally get to that. Please don't let me forget to talk about side effects. I keep forgetting to do it. All right, so we know it's efficacious over time. We know it's safe over time based on the Spravato studies, which technically we can't extrapolate to IV, and IV was the same thing. And we see the same thing in the clinic, okay? So the IM schedule is the same as this, except for this is very rigid. We follow it pretty religiously. If a patient comes in IM, we will recommend twice a week for a month and then once a week. But If they go 2 weeks in and they're like at remission, I may go ahead and take them to once a week and then once every 2 weeks based on their need. So we're a lot more flexible. These two are cash services, and this is insurance. Okay. So the price of the IM is $200 per treatment. And then CAP is kind of hybrid. So usually we'll charge for the ketamine administration. So most patients do IM, or we'll prescribe like an oral version of ketamine. It's called troche. So they have to pay for that at the pharmacy and bring it to the session. If they come and do CAP or work with a therapist while under the influence of ketamine, we'll usually have the nurse administer a shot when the therapist is ready. They'll pay $200 for that IM, and then we'll bill their insurance for the therapy component. So that's why I call it a hybrid. Okay. So that's kind of the tools in our tool belt. That's kind of the schedule. And finally, let's talk about side effects. Okay. Side effects. You know what? I actually don't want to do that. I actually have a really good lecture with everything on it. Would it be more thorough than me doing it off my head? But I'll show you that in a moment because I'm recording. So, all right. So this is important for you for how you remember all these freaking side effects for every freaking medicine. Like, you don't want to remember it based on every medicine. You want to remember it based on the mechanism of action and the receptor activity of the medicine. That's how you remember the side effects. Because otherwise you just remember a list. Okay? So we talked about ketamine being a sympathomimetic. Well, you get sympathetic side effects. So you get tachycardia, you get hypertension. And this is really important because that's one of the main things we need to monitor. So even Spravato, which is the weakest, can cause up to 40 milligrams of mercury increase in the systolic. So that's a big jump. You could be at 120 and go up to 160, okay, with Spravato. And it's about the same with the IV-IM, but possibly slightly higher, okay? So therefore, we don't start anybody's treatment if their blood pressure typically is greater than 145 systolic. Because if they hit that, they're going to be 185. And they're going to be a hypertensive urgency. Now, we haven't had any we had one patient have cardiovascular event. They had some angina or chest pain. But I knew that was a risk, so we kept the dose low. He just couldn't tolerate them. So he does do oral troches, but he can't manage the higher doses. So that's kind of a hard rule. If they are above that, a lot of times we'll do breath work, see if we can get it down. Clonidine, preemptively. Or I might prescribe it, or Tara might prescribe it for them to take it home prior to their ketamine treatment so they can come in, it can be in an acceptable range. I almost exclusively use clonidine. I don't like to do IV blood pressure medicine because I'm a psychiatrist, and I don't want to trigger some type of arrhythmia or drop their blood pressure, and we don't have all the equipment to protect them. And also I keep the ketamine in dose range so we don't have to do advanced cardiac monitoring. So some clinics would do like hook you up to a 12 lead AKG one. You got all these wires and stuff on you and stuff like that while you're doing that. But we just have a hard rule about our dose ceiling. So we don't typically do that. If there is some type of cardiovascular emergency, just call EMS. I don't know what's going on. They're freaking out. Heart rates, their blood pressure super high. We can't get it back down. EMS. Okay. That's what they do. Okay. But we manage in such a way that rarely happens. I might call EMS once a year. Okay. So that's a big piece of it is managing blood pressure. Other things, tachypnea, but it's hardly observable. So you'll look, if you get a chance to look at the notes, you'll see respiration rate 18, respiration rate 20, 15. It's not like they're like panting like a dog or anything like that. You won't see that, but that's just a quality of the medicine. Okay. Dissociation, we already talked about that. That's kind of part of the therapeutic effect too. But there's also a whole bunch of random stuff. One of the big ones is urinary complaints. So one of the big risks for ketamine is cystitis. Interstitial cystitis. Interstitial cystitis. That has been observed in people who abuse ketamine.
Does it cause like retention or something?
So it's like it can damage like the lining on the inside of the bladder and cause a fibrosis inside of the bladder, so the bladder can't contract to expel urine, which is bad. Okay. So on the follow-ups, we typically ask about any bladder complaints. Sometimes people have UTIs, dysuria. During the treatment, patients may have an increased urge to urinate. So we tell them to know liquid about an hour or two before the treatment, and they need to be NPO for at least 4 hours before the treatment because nausea and vomiting are a potential side effect for ketamine, and we don't want to have a full stomach, throw up, aspirate. That's a problem. So usually I like the nurse to ask, when was your last meal, et cetera, et cetera. Also, the patient need to know, sometimes they have patients at 3 o'clock. Their appointment's at 3, and they think they need NPL, so they eat all day long. And they come at 3, and then you give them their regular dose of ketamine, and it's like way stronger because you have nothing in nothing in the system to kind of have that buffer, no fats, no protein in the bloodstream to kind of buffer the ketamine. So be mindful of that. So those are things. There are other things they can have. You can have like dysgeusia. That's like a altered perception of taste, but usually people not eating things, they don't really notice it. That's possible. Obviously, dysphoria. You typically don't have hallucinations with this. It's not hallucinations. Now, if you're vulnerable to psychosis, that is a contraindication. That excessive excitation in the brain will make psychotic symptoms worse. So that's a contraindication for it. Other contraindications, we typically won't treat bipolar disorder that's primarily manic or rapid cycling bipolar. We will treat bipolar depression. So if a patient has greater than 4 manic episodes in a year, then that technically is rapid cycling bipolar. So patients should not come in and say, I've had 6 manic episodes when we treating them with ketamine. One of us missed that. Okay. So no psychosis. Any cardiovascular issues, cardiovascular system. So that would be history of myocardial infarction, strokes, hemorrhagic strokes, AV malformations. That's a no-go because that abrupt increase in blood pressure may increase their risk for having another cardiovascular event, and they won't qualify. So that's a good stopping point.